Please start.
Yeah, a warm good evening to everybody, and I hope you're all doing good and in your full phase of preparation for INI CET exam. Just tell me a quick yes if you can hear me. And am I clearly audible and visible to all of you? Yeah. So let's move forward to the INI CET questions of radiology. This is a rank deciding series that we have launched through DocTutorials, and let's get started with the first question here. Good evening, Ritu. Good evening, Anuj. And how was the exam? Did you guys write the exam in the app? How did you find the exam to be in? Did you write the exam? So please attend the exam in the app and look into these discussions. It will be giving you a good insight of the preparation. So let us look at the first one, a fallen lung sign. A fallen lung sign is seen in. Please remember, fallen lung sign, this on a CT scan or a radiograph talks about if imagine this is the trachea, this is the bronchus. When we have a fracture of the bronchus, the lung goes more inferiorly and laterally, and it goes away from the hilum inferiorly and laterally. This is suggestive of a fracture of a bronchus. So fallen lung sign on a radiograph or on a CT scan is suggestive of a fracture of bronchus. Next, pneumothorax. What were the signs that you learned in pneumothorax? Remember, deep sulcus sign. Deep sulcus sign. This is on a supine radiograph, right? And you also see the visceral pleural line. Visceral pleural line. Absent bronchovascular marking. All of this is pneumothorax. Pneumomediastinum. What were the radiological signs that you see in pneumomediastinum? You see a Spinnaker sign. Spinnaker sign. Also called as the angel wing sign or the angel wing. And another thing that you see in pneumomediastinum is you will see air under the heart. So you will see the diaphragm as a continuous line. So you see a continuous diaphragm sign. Continuous diaphragm sign. So Spinnaker sign or angel wing sign and continuous diaphragm sign. And one more sign in pneumomediastinum due to esophageal perforation. Esophageal perforation. When you have a Boerhaave syndrome, you will see a Necridius V sign. I hope you remember the air coming on the lateral aspect of the descending aorta and the medial hemidiaphragm. There is a Necridius V sign. So when you have the heart, when you have the thymus resting over the heart, this is the thymic cell sign. The thymic cell sign. And thymic cell sign is normal finding. Thymic cell sign is a normal finding that you have. But if you see the thymus lifted away from the heart, and you will see air under the thymus and also air under the heart, right? So this is the Spinnaker sign, the air lifting the thymus away from the heart, and also the continuous diaphragm sign. These are signs of pneumomediastinum. And when you have esophageal perforation, so imagine the esophagus perforates. Imagine this is the esophagus, and if it perforates, Boerhaave syndrome, you will see air coming on the lateral aspect of the descending aorta and the medial hemidiaphragm, forming the two limbs of the V. So that is called as Necridius V sign. Necridius V sign. These are the signs of pneumomediastinum. And one sign that I want you to remember for diaphragmatic rupture is when you have diaphragmatic rupture, the viscera are not supported any longer. So they fall on the posterior thoracic wall. This is called as dependent viscera sign. Dependent viscera sign. So these are important signs that I want you to remember. I hope this is clear. Pneumothorax, you will have deep sulcus sign and visceral pleural line. Pneumomediastinum, you have Spinnaker sign, angel wing sign. Also, we have continuous diaphragm sign and Necridius V sign, especially when we have pneumomediastinum due to esophageal perforation. Diaphragmatic rupture produces a dependent viscera. The viscera will fall onto the posterior thoracic wall. That is your dependent viscera sign. Okay. Good evening, Anuj, Karthik, and Lohit. I hope it's audible and clearly visible. Let's move to the next one. Are you clear? So I hope you remember fallen lung sign. Fallen lung sign is seen in fracture of bronchus. Fracture of bronchus. The lung moving inferiorly and laterally. Next. Glutamate peak on MR spectroscopy. What did you answer for this? Glutamate peak on MR spectroscopy. Anybody quickly? Glutamate peak on MR spectroscopy. Remember glutamate peak on MR spectroscopy. This is feature of hepatic encephalopathy as well as hypoxic encephalopathy. So hepatic and hypoxic encephalopathy, these show you glutamate peak. Can you tell me what is the peak that you see in meningioma on MR spectroscopy? Being a tumor, you will see choline. And there's another chemical that is elevated in meningiomas, that is alanine peak. So choline and alanine peak is meningioma. And where do you see, what is the thing that you see in medulloblastoma? This is also tumor, so you will see choline, and along with choline, you will see taurine peak. Taurine peak. So choline and alanine peak is seen in meningioma. Choline and taurine peak is seen in medulloblastoma. And we all know tuberculoma. Tuberculoma shows you lipid lactate peak, right? Lipid lactate peak on MR spectroscopy. And can I ask you, where do you see NAA peak, N-acetyl aspartate peak? This you should tell. Where do you see NAA peak? Where do you see NAA peak? N-acetyl aspartate. N-acetyl aspartate peak. This is feature of Canavan's disease, right? So Canavan's disease will show you N-acetyl aspartate peak. I hope you got this right, right? Fine. Okay. Let's move to the third one. I hope this is clear. Okay, good. Good chemistry, right? So let's go to the next one. Okay, let me see what have you answered for this. Next one. Very good, Anuj. Let's go to the next one. A month-old infant presents with abdominal distension, steatorrhea, vomitings, and failure to thrive. And on examination, there is hepatosplenomegaly. On the imaging, also, you can see the liver, the spleen are enlarged, and the imaging finding are given below what is the likely diagnosis. So this is a coronal CT scan given to you. These are your kidneys, right? And above the kidney, you can see these bilateral adrenal glands or suprarenal glands showing calcifications. So adrenal gland calcifications, especially bilateral adrenal calcifications, especially this is a 1-month-old child, steatorrhea, right? Vomitings, failure to thrive, bilateral adrenal calcification. This is classic of Wolman's disease. Wolman's disease, right? So Wolman's disease, right? So this is Wolman's disease, bilateral adrenal calcification, bilateral adrenal calcification. Neuroblastoma, remember neuroblastoma, this is a mass in less than 2 years age group. This encases vessels, elevates the aorta. It shows bone metastasis, skeletal metastasis. Encases vessels, elevates the aorta, does not invade the vessel. It encases and elevates the aorta. Bone metastasis is feature of neuroblast. Neuroblastoma, big name, right? Crosses midline. It crosses midline. Wilms tumor, on the other hand, does not cross midline. Wilms does not cross midline. Neuroblastoma crosses midline. That is about neuroblastoma. And Wilms tumor, let me do Wilms tumor also here. Wilms tumor, 3 to 4 years age group, invades the vessels. Lung metastasis, pulmonary metastasis is feature of Wilms tumor, does not cross midline. Small name, does not cross midline. Neuroblastoma crosses midline. So this is about neuroblastoma and Wilms tumor, and adrenal calcifications of in a infant age group, 1 to 2-month-old infant with failure to thrive. Think of Wolman's disease. Myelolipoma is a fat-containing lesion in the adrenal gland. There will be black area, okay, the fat-containing lesion in the adrenals. That would be myelolipoma. Lipoma will be dark on CT. Here you are seeing white areas. So this is bilateral adrenal calcification, Wolman's disease. Remember, Wolman's disease is deficiency of lysosomal acid lipase. Lysosomal acid lipase deficiency. Next. Coming to the next one. Patient with respiratory distress, the following chest radiograph is obtained. What is the likely diagnosis? Now look at the image. What did you answer for this? What did you answer for this? Look at, okay, can I wait? I'm looking for your answers. Very good, Abhinesh. Acid lipase deficiency is Wolman's. That is true. Anything, can you tell me what is the answer that you have written for this? A patient with respiratory distress, the following chest radiograph is obtained. What do you see on this chest radiograph is you are seeing the trachea is shifted to the right side. The heart is also shifted towards the right side. And look at the thoracic cage, right? You're seeing a left hemithorax completely opacified. So there is a volume gain here, causing the mediastinum and the trachea to shift to the opposite side. there is volume gain. Collapse, there is volume loss. The trachea would have shifted to same side, heart would have shifted to same side. So this is not collapse. Pneumonia, there is no tracheal shift, right? There is no tracheal shift in pneumonia, no tracheal shift. And this is not right pneumothorax. Right pneumothorax would have caused the trachea, if it is a massive pneumothorax also, it would have caused the trachea and the heart to shift to the opposite side. So it is not even pneumothorax. This is a massive pleural effusion. One of the cause for a massive pleural effusion could be an intrathoracic mass. This is pleural effusion, a massive pleural effusion, a hemorrhagic effusion that can be occurring due to a intrathoracic mass. This could cause this trachea and the mediastinum to shift to the opposite side. I hope this is clear. So the correct answer here should be A. The correct answer is A. Did you get this right, all of you? Is this clear, all of you? So you are seeing the volume gain, right? So volume gain is causing the trachea and the mediastinum to shift to opposite side. So you should think of conditions which can cause volume gain, especially a massive pleural effusion, right? And this can occur due to underlying intrathoracic mass. Okay, you get a CT scan done. You will see a underlying mass there. Clear with this? Very good, Santosh. Let's go to the next one. Let's go to the next one. Now, this is a bit longer. Just look at the question carefully. A 45-year-old widow presents with weakness in both legs and unsteady gait. She is having weakness in both legs and unsteady gait. Her family reports that her speech has also become slurred. Her condition has been progressively worsening since the past few weeks. HIV testing performed at the time of hospitalization was positive with a CD4 count of 45. So she's AIDS, right? She is having HIV and CD4 count less than 45. An MRI brain was advised, which shows multiple high signal lesions in the parieto-occipital region. So as an image shows you, so in the parietal and the occipital regions, you are seeing high signal changes. What is the likely diagnosis? So basically, AIDS patient, parieto-occipital involvement, multiple lesions that are there. Multiple lesions in the parieto-occipital lesion areas, patchy infiltrates that you are seeing. So patchy parieto-occipital area, multifocal area, right? White matter involvement. This is progressive multifocal leukoencephalopathy. Now, progressive multifocal leukoencephalopathy, let me just explain you this. Imagine these are the ventricles. This is the brain. And you are dealing with an AIDS patient. And you are seeing bilateral, multifocal, patchy infiltrate, especially involving the parietal and occipital areas. There are multifocal, patchy, multifocal, right? And predominantly in the parieto-occipital area. Parieto-occipital. This is all PML, progressive multifocal leukoencephalopathy. I hope you know the manifestations of in your patients with AIDS, right? The opportunistic infection. This PML is caused by JC virus, John Curtis virus, the John Curtis virus, right? This is a type of polyoma virus. So remember, bilateral, asymmetrical, parieto-occipital, patchy involvement, multifocal involvement. Think of PML. There is also another condition that is HIV encephalitis that can also occur in AIDS patients. But in HIV encephalitis, you see periventricular lesions, periventricular. And these will be bilateral and symmetrical in the periventricular white matter. So if this is the ventricles, this is the brain. If I am seeing bilateral periventricular white matter lesions, symmetrical lesions, periventricular lesion, AIDS patient, I think of HIV encephalitis. HIV encephalitis. Whereas PML, patchy, multifocal, as the name says, multifocal, patchy involvement. And white matter, which area? Parieto-occipital area. This is progressive multifocal leukoencephalopathy seen in AIDS patients, caused due to JC virus, polyoma virus. Now let's look at the next one. Let's look at the next one. A 18-month-old boy with multiple skin lesions, developmental delay, and seizures has an MRI brain done, which shows multiple small nodules that are isointense to white matter on T2-weighted imaging and project into the lateral ventricle. There is also a small, well-demarcated mass at the foramen of Monro, which is hyperintense on T2 and displays uniform enhancement. What is a likely underlying diagnosis? So basically, if you look at the question, there is a patient, 18-month boy with multiple skin lesions, and you are seeing developmental delay and seizures which is showing multiple small nodules which are projecting into the lateral ventricle, and a small demarcated mass at the foramen of Monro. So all of this goes towards tuberous sclerosis. Tuberous sclerosis. Now, please remember, these are ash leaf macules, the most common finding. The most common finding in tuberous sclerosis is ash leaf macule. And multiple small nodules projecting into the ventricles, these are subependymal nodules. The subependymal, just around the floor of the ventricle, subependymal nodules are there, which are isointense to the white matter. And at the foramen of Monro, this is the SIGA, subependymal giant cell astrocytoma. So these are the clues towards tuberous sclerosis, Bone-Willis disease. Coming to neurofibromatosis 1, what are the radiological finds that you have in neurofibromatosis 1? Please remember, NF1, they will show you bare orbit sign, the greater wing of sphenoid dysplasia, the absent innominate line, the bare orbit sign. You see pseudoarthrosis of tibia, pseudoarthrosis tibia. All the musculoskeletal defects that you have, the lateral meningocele, you'll have bare orbit sign, pseudoarthrosis of tibia. You may also see, scoliosis and vertebral body defects, all peripheral defects. These are all NF1. So in radiology, remember the greater wing of sphenoid dysplasia, the bare orbit sign, and the pseudoarthrosis of tibia. This is NF1. NF2 is Miss-Me lesions. NF2 is Miss-Me. What is Miss-Me? Multiple inherited schwannomas, meningiomas, and multiple inherited schwannomas, meningiomas, and ependymomas. So Miss-Me lesions is NF2. So these are all central lesions, right? In the brain, schwannoma, meningioma, ependymoma. Whereas NF1 is peripheral lesions. This is peripheral and NF2 is central lesions. Von Hippel-Lindau syndrome, what are the findings that you see in von Hippel-Lindau syndrome? You have a cystic lesion in the cerebellar hemisphere with a mural nodule. In an adult, this is hemangioblastoma. A cystic lesion in the cerebellar hemispheres with an enhancing mural nodule. You also see bilateral RCCs, renal cell carcinoma, clear cell RCCs. You may see retinal hemangioblastomas, risk of pheochromocytomas, right? You also have pancreatic cyst. Okay, an important finding of VHL is the presence of multiple pancreatic cysts. So all of this is von Hippel-Lindau syndrome. Retinal hemangioblastomas, cerebellar hemangioblastomas, bilateral RCCs, pancreatic cyst, and increased risk of pheochromocytoma. And in von Hippel-Lindau syndrome, I also want you to remember one ENT tumor. Can you tell me what ENT tumor you will have in von Hippel-Lindau syndrome? There will be associated endolymphatic sac tumors in von Hippel-Lindau syndrome, endolymphatic sac tumors, right? So this is von Hippel-Lindau syndrome. So the answer for our question, which had the nodules projecting into the ventricle, a SIGA, subependymal giant cell astrocytoma, and foramen of Monro, all of this is tuberous sclerosis. Now, answer this question. CNS lymphoma is usually, a lesion which is crossing it's a hyperdense lesion crossing the corpus callosum, right? So it's a very different lesion that you have in AIDS patients. So CNS lymphoma, it is a hyperdense lesion which invades the corpus callosum, right? So that is CNS lymphoma. Anyways, what is this lesion? Seventh question, identify the location of the pathology in the given chest radiograph. Anterior mediastinum, posterior mediastinum, hilum, lower lobe. Where do you think is the problem? Where do you think is the lesion here? Okay, one answer I'm getting is anterior mediastinum. Any other thing? Okay. Uh, First of all, is it in the right side or left side? Did you at least see the lesion? Where is it? Right side or left side? Look at the chest radiograph and tell me where is the lesion, right side or left side? Right or left? Where are you finding the pathology? Right side or left side? At least tell me, right or left? I'm waiting for your answers. Right side or left side? Right side. Okay. Which zone? Upper zone, middle zone, lower zone. Where is it? Where do you think it is? Right upper zone. Okay, all of you are answering it right. This is right upper zone. That what I want you to look at is how is the opacity? How is the radio opacity seen? Is it ending at the clavicle or extending beyond the clavicle? That is what you have to see. There is a sign that you studied called as cervicothoracic sign. Cervicothoracic sign. What does it say is imagine a lateral view. Imagine a lateral view, right? In a lateral view, this is the sternum and this is the vertebrae that you have. I'm looking at a lateral view, right? And this is the clavicle that we have. Okay, imagine this is the clavicle. So a anterior mediastinal mass, and this is how the thoracic cage is. Anterior mediastinal mass will appear as if it is ending at the clavicle. A posterior mediastinal mass will appear as if it is extending above the clavicle. When you see a frontal radiograph, and if you see the lesion extending above the clavicle, this is in the posterior part, right? It is in the posterior part. If it is ending at the clavicle, so if you see opacity ending at the clavicle like this is anterior media. It is ending at the clavicle. If it is extending beyond the clavicle, then think of a posterior mediastinal mass. So this is in the posterior mediastinum. Posterior mediastinum. Same thing in the lower part also. There is a thoracoabdominal sign. One is cervicothoracic sign and there is a thoracoabdominal sign. If you see a lesion in the anterior aspect of the lung, it seems to be ending at the diaphragm. If you see in the posterior part of the lung, it seems to be going extending below it appears to be extending below the diaphragm on the radiograph. This is thoracoabdominal sign and a cervicothoracic sign. So if you see the opacity extending beyond the clavicle in the upper part, right, extending above the superior border of the clavicle, think it to be in the posterior mediastinum. Posterior mediastinum. Are you clear with this? Is this clear? If the lesion is extending into the cervical area, into the above the clavicle, this is a posterior mediastinal lesion. Next. Next, coming to the next question, eighth one. A diabetic patient with borderline renal function develops thick woody skin after undergoing a contrast study. Which contrast agent has been used in this patient? This you should answer. Very good, Anuj. Next, can you tell me what is this question? A diabetic patient with borderline renal function develops thick woody skin after undergoing a contrast study. Which contrast agent has been used in this patient? Iohexol, gadolinium, gastrografin, or Sonoview. What did you answer for this? Very nice. We got the right answer. This is gadolinium. This is gadolinium. This is gadolinium. Now, please remember, gadolinium produces dermal fibrosis, skin fibrosis, which progresses to produce multi-organ fibrosis. Multi-organ fibrosis. This is your nephrogenic systemic fibrosis, NSF. This is something which we all know, nephrogenic systemic fibrosis. Right? So nephrogenic systemic fibrosis is a complication with gadolinium. Gadolinium. Also remember, gadolinium is toxic, always coupled with DTPA. Right? You should always give it coupled with DTPA. It is teratogenic also. Teratogenic. Okay? So avoid it in pregnancy. Coming to iohexol, iohexol produces contrast-induced nephropathy or post-contrast AKI. Post-contrast AKI. Contrast-induced nephropathy, this is increase in serum creatinine by more than 0.5 milligram per deciliter. Post-contrast AKI, this is increase in serum creatinine by more than 0.3 milligram per deciliter. This can occur with iodinated contrast. So it is important that we don't give gadolinium to patients with renal failure. Neither will give iodinated contrast agents when you are having elevated serum creatinine. Gastrografin is a ionic monomer. Gastrografin is basically a salt of diatrizoid. Okay, it is salt of diatrizoid. So it is ionic monomer, a very high osmolar contrast agent. So being a high osmolar contrast, it will be having a risk of pulmonary edema, right? So it can cause pulmonary edema. And also gastrografin, remember, because it is high osmolar, can be used for therapeutic enema in constipation patient and also to relieve meconium in your, cystic fibrosis patients or to relieve meconium. So it's basically high osmolar that I want you to remember. Ionic monomers. Ionic monomers, these are high osmolar agents. With these are, used to relieve constipation in for therapeutic enema. Sonoview, this is ultrasound, sono ultrasound. And for this, there is no need to get a renal function test, pre-contrast RFT are not needed because these are micro bubbles of gases. No pre-renal pre-contrast RFT needed. No pre-contrast RFT is needed. For ultrasound contrast, remember ultrasound contrast, these are gas bubbles, micro bubbles of gases. These are micro bubbles of gases. Which gas is used? Sulfur hexafluoride gas. So this is excreted by lungs. Sulfur hexafluoride gas, it is excreted by lungs. So ultrasound contrast agents, you don't have to worry in chronic kidney disease patients. Which contrast agent is safe in chronic kidney disease? Your ultrasound contrast. Ultrasound contrast is safe in chronic kidney disease, right? Next. Coming to the next question, ninth one. This is a repeat question, PYQ. I hope you have got this right. A 26-year-old patient with stab injury to the right side of the chest presents to the ER. His heart rate is 120 beats per minute, BP is 90/60, and respiratory rate is 28 per minute. On auscultation, the breath sounds are reduced on the right side. The supine radiograph is given. What is the diagnosis? So there is injury onto the right side of the chest, right? And the patient is having hypotension, and pulse rate is also increased. Auscultation shows decreased breath sounds on the right side. So the problem is on the right side. Stab injury on the right side, decreased breath sounds on the right side. A supine radiograph is shown. So you are seeing a opacification of the right hemithorax. Injury, opacification of right hemithorax. Think of hemothorax. So this is right-sided hemothorax. Right-sided hemothorax. Next. Okay. Look at this. A patient has progressive red swelling. Identify the condition based on the given CT scan. What did you mark this as? Look at the CT scan. There is a swollen red eye on the right side. There is a swollen red eye on the right side. So the CT scan image is also given, concentrated on the right side. So you see that the preseptal area is showing thickening. There is a preseptal cellulitis in the patient. So this is a preseptal cellulitis that you have, right? Preseptal cellulitis that you can see, right? So this is preseptal cellulitis. Orbital cellulitis will be here, right? So this is the orbital cellulitis area, right? So subperiosteal abscess will be like this. Subperiosteal abscess will have pus collection here. So this is in the anterior part. So this is preseptal cellulitis. And yes, we can see sinusitis, but not only sinusitis. We can see some sinusitis, but it's not just sinusitis. You're actually seeing the clinical clue is also given, red swollen right eye, and you can also see thickening of the preseptal area, that is preseptal cellulitis. We have a Chandler classification, okay? If it is involving the preseptal area, right? The preseptal area, it is type 1. If it is causing orbital cellulitis in the orbital area, only inflammation there, no pus, just inflammation, that is orbital cellulitis type 2. If you see subperiosteal collection, there is an abscess there, that is type 3. And if you see pus in the orbit, that is orbital abscess. And if it is going and involving the cavernous sinus, that is your type 5. So this is the Chandler classification. So or preseptal cellulitis is the answer here. You can see clearly the preseptal area is showing the inflammation there. So this is the Chandler classification that we have. So do not confuse. Orbital cellulitis is type 2, orbital abscess is type 2. Next. A 2-year-old child presents with breathlessness. On chest radiograph, identify the object seen on the radiograph. Is it button, battery, coin, ball, or bottle cap? What do you think is this? What do you think is this? If you look carefully, what do you see here? You can see a halo around it, a double ring around it. So if you're seeing a double rim or a double ring, and on a lateral radiograph, if I see a lateral radiograph, I'll be able to see a step off. If I see a lateral, if sometimes they give you lateral radiograph, they'll show you this step off. These are suggestive of button battery. These are suggestive of button battery. So two signs that I want you to remember for button battery. On the frontal radiograph, you will see this double ring. And on a lateral radiograph, you will see the step off. Okay, so a step off is seen. This is button battery. So this is button battery. Button battery in the esophagus is an emergency. You have to go for urgent removal by esophagoscopy, right? So that is important. Double ring or the double rim sign. That is button battery. Next. Okay, let me see how many of you have answered correctly. I'll see your answers. Please answer this. What is the most sensitive investigation for localizing parathyroid adenoma? Parathyroid tumor imaging, Okay, to localize the parathyroid adenoma, what is the most sensitive investigation? To localize parathyroid adenoma. To localize parathyroid adenoma, what is the most sensitive investigation? Okay, I'm getting different answers. So the answer for this, okay, is 4D-CT. The first should be 4D-CT. A 4D-CT plus sestamib SPECT. This is found to be more sensitive actually. A combination is more sensitive. This is better than 4D-CT. This is better than only doing 4D-CT. A combination is better. This is better than doing sestamib SPECT. And this is better than just doing sestamib. They have bothered you many times on this topic. Please remember, the more sensitive investigation to localize parathyroidenoma is 4D. Answer it only if there is 4D-CT, not CT or CECT. Answer it only if there is 4D-CT in your options. Okay, 4D-CT should be there. So, and a combination is given, that's best. A combination is given, that's best. Otherwise, if they give you independently, choose like this. 4D-CT should be your better answer. Next should be sestamib SPECT. Obviously, 3D imaging. SPECT is 3D imaging. That is better than just doing a sestamib scan. So 4D-CT better than sestamib SPECT, better than sestamib. This is the investigations to localize the more sensitive investigations to localize the parathyroid adenomas. Next, 13. Identify the mark structure on the given knee MRI. Can you tell me what is this? Is it a normal ACL, normal PCL, ACL tear, or PCL tear? Which one? DCT. 4D-CT. 4D computerized tomography. Right? Four dimensional computerized tomography. 4D-CT. It is not DCT. Okay, it is 4D. 4D-CT. Okay. Like we have 3D and 2D, right? So 4D. You will also look at the time factor, the RTL enhancement of parathyroidenoma. You take axial, sagittal, coronal imaging, and you also see the RTL enhancement with time. So that is what is the fourth dimension that you are seeing. That is 4D-CT. Okay, 4 dimension. Okay, 13th one. What did you answer for the 13th one? Very nice. Very nice. So you are able to see, first of all, please remember the normal ACL, PCL, these are dark, right? Signal whites on MRI. If you look at what are the signal whites on MRI, which are dark on both T1 and T2. Dark on both T1, T2. They should always be dark both on T1 and T2. These are called signal whites. These are A, B, C, D, and F. Air is always dark on MRI. Bone is always dark, whether it is T1 or T2. Calcification is always dark. Dense fibrous tissue. Dense fibrous tissue, like ligaments, tendons, and menisci. Ligaments, tendons, menisci. They're always dark. So ACL, PCL normally should always be black. This is how a question mark like area. This is PCL. Look at the attachment on the tibia. Don't look at the femur. Look at the attachment on the tibia. The posterior one is PCL. It has a question mark like area. Question mark like area. And this attached on the anterior part of the tibia, this is ACL. They'll be black. They'll be black normally. They're all hypo signal whites. Signal whites. ACL and PCL. They're all black. Normally they should be black. There will be signal whites. If you see fluid, there'll be all whitish areas like this. So that indicates there is edema, there is injury to that area, and the arrow is pointing towards the injury to the ACL, right? So there is injury to the ACL. So the better answer here is ACL tear, ACL tear. Normally they are black. If you see white areas, that indicates there is edema, there is injury to that area, right? So this is ACL tear. Next. Then, where do you see bow tie appearance on a sagittal MRI? If I'm seeing a bow tie appearance on sagittal MRI, bow tie appearance on sagittal MRI. This is menisci. This is how menisci will appear on the sagittal MRI. Question mark like area is PCL. Question mark like area is PCL. Bow tie appearance is the normal appearance of the menisci. If you see, you can see a part of it here, right? So this, like this. These are the menisci. You see that bow tie like area, okay? It's a different section, but if you see a bow tie like area, that would be the menisci. Next. A digital subtraction angiography of a 35-year-old is given. What is the likely diagnosis? What do you think is this image showing you? So you can see the contrast is dark. So when the contrast inside the blood vessels is black, this is digital subtraction angiography. And you are seeing multiple corkscrew-like collaterals and poor perfusion of the digits. So there is poor perfusion of the digits, but you are seeing multiple corkscrew-like vessels, corkscrew collaterals. If you are seeing corkscrew collaterals, this is Berger's disease or thromboangiitis obliterans, thromboangiitis obliterans. You are seeing these corkscrew collaterals on imaging, corkscrew collaterals. So if you see poor perfusion of the major vessels, but multiple corkscrew collaterals on imaging, think of Berger's or thromboangiitis obliterans. Okay, this one, a limb radiograph of a child with cardiomegaly and digital anomalies. So the radiograph is given. This is a child with cardiomegaly. Child is there with cardiomegaly. And also there are digital anomalies. And you can also see there is absent radius on the radiograph. On the radiograph, you are seeing absent radius. What is coming to your mind? What is coming to your mind? Very good. Very good. This is Holt-Oram syndrome, right? Autosomal dominant condition. You're having radial defects, right? And cardiomegaly also is there. So all of these go in favor of Holt-Oram. Now, osteogenesis imperfecta, think of diaphyseal fractures, antenatal fractures, right? Osteogenesis imperfecta and non-accidental injury of the baby, battered baby syndrome. Non-accidental injury will have metaphyseal corner fractures. There will be a corner fractures. Whereas diaphyseal fractures is osteogenesis imperfecta. In non-accidental injury, you will have metaphyseal corner fractures, right? So metaphyseal, when the baby is being shaken violently, so there will be metaphyseal corner fractures. So when the baby is shaking violently, you will see the metaphyseal corner fractures in battered baby syndrome or non-accident injury of the baby. Whereas diaphyseal fractures is feature of osteogenesis imperfecta. Antenatal fractures will be seen with osteogenesis imperfecta, antenatal fractures. Achondroplasia, you know a lot of things. You'll have the bullet-shaped vertebra, chevron sign, right? So you see this metaphyseal areas having the V-shaped lucencies. That is your chevron sign. And you also see Chambin glass pelvis, horizontal acetabulum, tombstone iliac bones. Okay, the chevron sign. That is achondroplasia. Any finding that you remember in thanatophoric skeletal dysplasia? Can you think of any finding that you see in thanatophoric skeletal dysplasia? Remember T for T, telephone handle appearance of the femur. Telephone handle appearance of femur. So the femur is curved and short curved femur appearing like a telephone handle. So telephone handle appearance of the femur. This is thanatophoric skeletal dysplasia. Thanatophoric skeletal dysplasia. So if you see absent radius, cardiac and autosomal dominant and absent radius in the patient, child with cardiomegaly, absent radius, this is Holt-Oram syndrome. You can see absent radius in also TAR syndrome, that is thrombocytopenia and absent radius and vectoral anomalies. So these are the conditions which may be associated with radial ray anomalies, right? So please remember, if it is a child with cardiomegaly and radial defects, think of Holt-Oram syndrome. So you can see in this image also, you're having a child with cardiomegaly and look at the bones. Okay, there is radial defect. So cardiomegaly and this is, and also phalangeal digital problems. This is all Holt-Oram syndrome. Next, 16th. A chest radiograph and abdominal CT are given. So your chest radiograph is there and abdominal CT is given. A middle-aged male complaining of nagging pain abdomen for the past 2 weeks. What is the probable diagnosis? Did you get this right? Is it porcelain gallbladder, hydatid cyst, pyogenic liver abscess, or amoebic liver abscess? Did you get this right? Very good. Very good. So if you see the radiograph carefully, you can see there is a calcification in the right hypochondrium. So you see a calcific lesion in the right hypochondrium. On a CT scan also, you see a cystic lesion showing a peripheral cyst wall calcification. You can see the cyst wall calcification. So such cyst wall calcification, a cyst wall calcification, this is feature of hydatid. Cyst wall calcification is feature of hydatid. A pyogenic liver abscess may show you cluster sign. right? Small micro abscess uniting and forming a large unilocular list. Amoebic liver abscess is also a unilocular lesion. Okay, we can see the liver abscess showing a double rim-like appearance, unilocular appearance. But the cyst wall calcification, if you are seeing a multiloculate appearance or a cyst wall calcification, floating membrane, water lily sign, all of this is hydatids. If you see a oval-shaped calcification, if the calcification was oval shape on the wall of the gallbladder, on the peripheral wall of the gallbladder, if you see calcification, that would be porcelain gallbladder, a pre-malignant condition, right? So this is pre-malignant for gallbladder cancer. You will go for prophylactic cholecystectomy, right? So prophylactic cholecystectomy should be done for porcelain gallbladder. So please remember, is it a cyst wall that is calcified or is it a gallbladder that is calcified? If it is gallbladder wall calcification, that is porcelain gallbladder, you need to go for prophylactic cholecystectomy because it has risk of gallbladder cancer, porcelain gallbladder. Hydatid cyst, please remember the presence of cyst wall calcification is suggestive of hydatid. Cluster sign, where multiple microabscess unite and form a large abscess. A diabetic person, a person who is having biliary procedures done, high-grade fever and chills, think of pyogenic liver abscess. Younger patients, mild fever, mild pain, right? Think of amoebic liver abscess. Elderly patient, right? Think of pyogenic liver abscess. High fever, think of pyogenic liver abscess. History of diarrhea, think of amoebic liver abscess. History of diabetes, think of pyogenic liver abscess. Okay, I hope you know those things. Next, what did you answer for this? A soft marker of aneuploidy. As a soft marker of aneuploidy, nuchal skin fold thickness scan in a pregnant female should be done between 6 to 10 weeks, 11 to 14 weeks, 18 to 22 weeks, or 28 to 32 weeks. What did you answer for this? As a soft marker of aneuploidy, nuchal skin fold thickness scan we do. And what time should you do a nuchal skin fold thickness scan? At what gestational age we should do this nuchal skin fold thickness scan? Very good. Very good. So please remember, 11 to 14 weeks is for nuchal translucency. Nuchal translucency. Nuchal skin fold thickness is between 18 to 22 weeks of gestation. Nuchal skin fold thickness is different. Nuchal translucency is different. Nuchal translucency, you look at the lucent area behind the neck. Nuchal skin fold thickness, you look at the skin fold behind the occiput. The normal cutoff in case of nuchal translucency is 3 mm. Nuchal skin fold thickness is less than 6 mm. If it is more than 3 mm, or if nuchal translucency is more than 3 mm, or if nuchal skin fold thickness is more than 6 mm, think of aneuploidy. This is suggestive of aneuploidy. It's a soft marker of aneuploidy. So nuchal translucency is 3. Nuchal skin fold thickness is 6 mm. Nuchal translucency is done between 11 to 14 weeks of gestation. More accurately, 11 to 13 weeks, 6 days. 11 weeks to 13 weeks, 6 days. And nuchal skin fold thickness scan is a scan that is done between 18 to 22 weeks of gestation. Next, when do you do TIFA scan, by the way? Same thing, right? TIFA scan. This is for fetal anomalies, targeted imaging for fetal anomalies. This is also done between 18 to 20 weeks of gestation. You can go up to 22 weeks, 18 to 20 weeks of gestation around the same time when we go for this nuchal skin fold thickness. To look at this fetal anomalies, the TIFA scan should be done between 18 to 20 weeks of gestation. So this is nuchal skin fold. You look at the skin fold behind the occiput. And this is a nuchal translucency that you look behind the neck in the baby. So nuchal skin fold thickness is different. Nuchal translucency scan is different. Next, reverse bat wing sign on chest X-ray. Where do you see reverse bat wing appearance on chest X-ray? Reverse bat wing opacities on chest X-ray are seen in. Anybody? Reverse bat wing appearance. Pulmonary edema, PCP pneumonia, viral pneumonia, chronic eosinophilic pneumonia. Reverse bat wing opacities. Remember, pulmonary edema produces batwing-like perihilar opacities, not reverse batwing. It produces batwing-like opacity. What do you mean by batwing? Imagine this is a lungs, and these are the hilum that we have. So if you see perihilar opacities in a batwing configuration, confluent grouped opacities, this is what is batwing opacities. This is pulmonary edema. But even in your PCP in AIDS patients, this also shows perihilar opacities in fever and the AIDS patient if you are having perihilar opacities. Around the hilum, you see lot of infiltrates, perihilar opacities are there. In an AIDS fever patient, think of PCP pneumonia. So these are perihilar lesions. Viral pneumonia, this will be interstitial pneumonias. So these are reticular opacities. So if you see bilateral lung fields, you see network-like lines. In multiple network-like reticular interstitial septal thickening. Okay, so all this reticular opacity is bilateral. That is how a viral pneumonia will appear. It's an interstitial pneumonia. Chronic eosinophilic pneumonia will show you a reverse batwing-like appearance. Reverse bat. So these are peripheral opacities. So imagine this is the chest radiograph, and you will see peripheral opacities. This is what is, they are sparing the perihilar region. They are involving the periphery of the lung. This is what is reverse batwing. And reverse batwing is chronic eosinophilic pneumonia. Remember, reverse batwing for chronic eosinophilic pneumonia, it can also be seen in organizing pneumonia. Organizing pneumonia. And if a trauma case is given, think of lung contusions, okay, pulmonary contusions also. So these are the causes. But remember, chronic eosinophilic pneumonia will show you reverse batwing appearance. Batwing appearance is pulmonary edema. Perihilar opacity in AIDS patients, also think of PCP pneumonia. Viral pneumonia will be reticular opacities, okay, in bilateral network-like opacity, reticular lines, like, opacities, that is viral pneumonia. Chronic eosinophilic pneumonia will produce you perihilar, not perihilar. Perihilar sparing will be there. Peripheral involvement will be there. That is what is called as reverse batwing appearance. There is sparing of the perihilar area and the involvement of the periphery of the lung fields. This is chronic eosinophilic pneumonia. Also seen with organizing pneumonia and pulmonary contusions in a setting of trauma. Next, where do you see reverse rim sign? Reverse rim sign on contrast studies of kidney. A reverse rim sign. Yes, Devanshu. Bronchial adenocarcinoma, bronchoalveolar carcinoma also can show you the reverse. Okay, if you want to write, you can write it. You can also be seen with bronchoalveolar carcinoma. Reverse batwing, bronchoalveolar carcinoma also can show you. So three, remember these two first. Try to memorize these two at least. But if you want to learn, you can learn. It can also be seen in bronchoalveolar carcinoma or pulmonary contusions also. Mainly learn chronic eosinophilic pneumonia and organizing pneumonia. These two you keep in mind, but can also be seen in pulmonary contusions or bronchoalveolar carcinoma. Next, reverse rim sign. Reverse rim sign. Now, please remember, rim sign is different, reverse rim sign is different. Rim sign will be seen in chronic gross hydronephrosis. Chronic gross hydronephrosis will show you rim sign. Whereas renal cortical necrosis, this will show you a reverse rim sign. Reverse rim sign. So please understand, rim sign is different, reverse rim sign is different. Let me show you the images. Rim sign is when you have a gross hydronephrosis, there is thinning of parenchyma, atrophy of the parenchyma, and the parenchyma will be thinned out and atrophic and seen only as a crescent or a rim at the periphery. That is seen in chronic gross hydronephrosis. That is a rim sign. But in cortical necrosis, when you have renal cortical necrosis, the cortical area is necrosed. So you see a reverse rim sign. Okay, rim sign is seen in chronic gross hydronephrosis, a reverse rim sign. That is feature of renal cortical necrosis. Renal cortical necrosis. Differentiate a rim sign and a reverse rim sign. Reverse rim sign, renal cortical necrosis. This is an easy one that I have kept for you. I hope all of you got this right. What is this image showing you? What is this image showing you? How is the bone? Basically, how is the bone? The bone is black. The pelvic bone, the ribs, right? All of this is dark. So this is MRI. And you are seeing the pelvic calcium system, the ureter and the bladder. So this is MR urogram. MR urogram. So CT, the bones are white. The CT, the bones are. IVP is a radiograph. You all know, right? You will see the bones and the IVP, intravenous pyelography. MR urography, the bones